1, 2,
And review, somebody female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep your card again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is also dropping.
45 minutes of CPR and no return of circulation. Okay.
Hey guys, this right here is going to be the pharmacology section or critical care pharmacology section. And this one is specifically going to be for your RSI drugs. Now, RSI is rapid sequence induction, or that's basically going to be your intubation pathway or your intubation algorithm, however you want to look at it. So you have a few popular and common sedatives, which are going to be etomidate, ketamine, propofol, and Versed, or midazolam, right, for generic name. And then your paralytics your two big ones are going to be rock and sux. All right. So succinylcholine and rocuronium are competing for like top spots. But rock has a longer duration than sux does. So if you got someone that's going to be a difficult intubation or a difficult tube, you're going to be probably using rock because you get that 30 to 60 minute window of paralytic properties. But you also have vecuronium. That right there was the med that Redonda Vaught accidentally gave her patient before she went for MRI or CT. And she gave way too much of it and robbed the lady's drive to breathe quite physically. So that's Vec. But the two most common drugs that I have seen used for intubation is definitely going to be etomidate and rock. Now, guys, because we all operate on a perverted mind, just always, always, always remember you're going to date someone before you suck them, or you're going to date someone before you rock their world. Okay? Easy way to remember it. So you're always going to put someone under. You're always going to sedate them before you paralyze them. Okay? So date before you suck, date before you rock. Right? So etomidate, rock, etomidate, sucks, or ketamine, rock, ketamine, sucks, whatever you guys want to use. Right? But that's kind of the way to do it. Okay? So all of the drugs that are going to be annotated with RSI are going to be your RSI drugs. Now, the exceptions are probably going to be midazolam and ketamine. Midazolam because it acts as also an anxiolytic, but it's not typically used for that, but it can be. And then ketamine is another chic drug that's coming back into popularity. After it was taken out of popularity, it's coming back with a vengeance. So just a quick thing on ketamine is low dose. You're going to be getting into that psychotherapeutic range where they use it for like CBT and stuff like that. And then you have the mid-range dose, which is going to be for pain control, like up to 50, I think it's 50 mics or maybe 50 megs. One of the two, it's 50 something. And then you have your mod sed, which is going to be anything over like 50 and above, right? From what I understand, and again, this is me, I'm going to learn it just like you guys. But from what I understand, ketamine does not really have the properties of slowing down respirations, but that's just what I've been told. And we'll find out together when we listen to the episode over ketamine. Okay. So again, this is going to be your RSI drugs. They're going to be annotated as such with RSI. And it's important that you know your RSI drugs because you as the nurse will be pushing etomidate. You as the nurse will be pushing rock. You as the nurse will be pushing Versed for these critically ill patients that you need to take their airway. Okay. So just kind of keep that in the back of your mind why you're giving these meds and listening to this, because you will be needing to know this as you're giving this med. Okay? All right, guys, enjoy the episodes.
Imagine a patient in the ER. Like, their airway is rapidly closing.
What a total worst-case situation.
Exactly. And you have exactly 60 seconds to paralyze every single muscle in their body so you can insert a breathing tube.
Yeah, the pressure is unimaginable.
But here is the catch. If you choose the wrong drug from the Pyxis machine, or if you don't fully understand the patient's medical history, you could instantly stop their heart.
I mean, it is the definition of a high-stakes scenario. There's absolutely no margin for error.
Welcome to another deep dive. Today, we are stepping into the intense world of critical care pharmacology.
We really are.
Yeah, we're taking on the mission of like an elite clinical pharmacist and a nursing instructor. We're aggressively applying the 80-20 Pareto principle to one of the most potent medications in emergency medicine.
Succinylcholine.
Succinylcholine.
And we are going to cut through the noise for you today. Instead of just memorizing a dry list of side effects, we are going to look at the underlying cellular biology.
Because when you understand the why behind this drug, the nursing interventions just become common sense.
Exactly. The exam answers, the clinical decisions, they just click.
Okay, let's unpack this. Before we get to the terrifying black box warnings, I need a baseline. What exactly are we dealing with when we pull a vial of succinylcholine?
Well, at a fundamental level, succinylcholine is a peripherally acting muscle relaxant. Specifically, it's a short-acting, depolarizing neuromuscular blocking agent.
The depolarizing NMBA.
Right. You'll often hear clinicians just call it an NMBA. And to understand why it's both an absolute lifesaver and a massive hazard, we really have to start at the neuromuscular junction.
We have to follow the chain reaction.
Exactly. From the mechanism to the physical effect, right down to the clinical use.
All right, let's talk about the normal mechanism first.
Yeah.
Usually when I want to move my arm, my brain sends a signal.
Standard physiology. Yeah.
Calcium rushes in, and my nerve endings release acetylcholine HE into the gap between the nerve and the muscle.
Right, the synaptic cleft.
And then that acetylcholine binds to receptors on the muscle, sodium channels open up, and boom, the muscle contracts.
That's the elegant, healthy process, Acetylcholine does its job, and then an enzyme called acetylcholinesterase comes along immediately.
Like a little cleanup crew.
Exactly. It sweeps the acetylcholine away, and the muscle relaxes. Well, acetylcholine violently disrupts that system.
Because it structurally mimics acetylcholine. Right?
Yes. So it competes directly for those exact same receptor sites on the motor end plate.
Okay, so it's sort of like a fake VIP pushing past acetylcholine at a club. The fake VIP acetylcholine shoves their way to the front, grabs the door to the club, and throws it wide open so all the sodium rushes in.
I love that.
But then they just refuse to leave the doorway.
Your VIP analogy is right on track, but let's take it a step further. This fake VIP isn't just holding the door. I mean, he has essentially jammed the lock.
Oh, wow.
Yeah. Just like acetylcholine, this drug binds and activates the receptor, causing a massive, widespread membrane depolarization. But the critical difference is that acetylcholine is completely immune to acetylcholinesterase.
That cleanup enzyme we just talked about.
Right.
Wait, so the bouncer can't kick the fake VIP out?
Precisely. Because it resists degradation by that specific enzyme, the drug just stays stubbornly bound.
Holding the door open.
Holding the sodium channels open, forcing the muscle into a state of prolonged depolarization and completely preventing it from resetting.
And that cellular traffic jam translates directly into what we see standing at the bedside, doesn't it?
Oh, absolutely.
When you push this drug intravenously, you actually witness that massive initial depolarization happening all over the body. Like, it causes visible muscle fasciculations.
Yeah, you see intense rippling twitches across the patient's chest, their limbs, their face.
Which honestly looks terrifying if you aren't expecting it.
It really does.
But those twitches are followed immediately by profound skeletal muscle paralysis. And the clinical literature notes this happens in a very specific descending order.
Right, it starts at the top.
Yeah, it starts with the levator muscles of the face and the glottis, which is exactly what you want for intubation, obviously. Then it works its way down to the intercostals, the diaphragm, and finally all the other skeletal muscles.
And because of that profound rapid paralysis, its primary therapeutic use is as an adjunct to general anesthesia.
to make inserting the breathing tube easier.
Exactly, to facilitate tracheal intubation and to provide complete skeletal muscle relaxation during surgery, mechanical ventilation, or even electroconvulsive therapy.
But here's the critical clinical question. If you are a critical care nurse or a physician standing in the ICU, why pick this specific vial?
That's the 80-20 question right there.
Right, because there are plenty of non-depolarizing paralytics out there. You have rocuronium or vicuronium. So why succinylcholine?
Well, it comes down to two factors that make it an absolute goldmine in an emergency: speed and short duration.
Speed is everything in an airway crisis.
Exactly. Let's look at the onset. When administered intravenously for a rapid sequence intubation, or RSI, it creates ideal intubating conditions in a lightning-fast 30 to 60 seconds.
Under a minute to total flaccid paralysis.
Less than a minute. And just as importantly, it wears off in just 4 to 6 minutes.
Right.
It is the ultimate rapid-on, rapid-off paralyzer.
Wait, hold on. If that cleanup enzyme, acetylcholinesterase, can't break it down, how does it wear off so fast? I mean, why aren't they paralyzed forever?
That's a great point. The body actually has a backup system. The drug diffuses away from the neuromuscular junction and gets rapidly hydrolyzed by a completely different enzyme.
Oh, really?
Yeah, one that's just floating in the blood plasma. It's called plasma-pseudocholinesterase.
Okay, plasma-pseudocholinesterase, that's a mouthful, but I see why it's crucial. Let's place ourselves in that clinical scenario to see why this 4 to 6 minute window really matters.
Let's do it.
You are in the emergency department. You have a trauma patient who needs immediate intubation, but they have a very difficult airway. Maybe severe facial trauma or massive swelling.
Right.
You need absolute paralysis right this second to get the tube past the vocal cords.
But you also have to anticipate failure. If it's a difficult airway, there is a very real chance the provider might miss the intubation attempt.
Yeah, which is terrifying.
It is. And the absolute last thing you want is a drug that locks the patient in a paralyzed state for an hour while you are frantically struggling to ventilate them with a bag valve mask.
Right. If you failed to secure the airway, you need that patient to regain their muscle tone and start breathing on their own again as quickly as possible.
And succinylcholine gives you that safety window.
It is the weapon of choice when you need them paralyzed immediately, but might need them breathing again in 5 minutes.
That's the massive therapeutic benefit. But we have to pivot back to that cellular mechanism.
Oh boy, the danger zone.
Yeah, because holding that biological door wide open comes with a very dangerous metabolic price tag.
Here's where it gets really intense. When that door is jammed open during depolarization, sodiums are rushing into the muscle cell, but something else is rushing out. Potassium.
A lot of potassium.
Massive amounts of potassium leak out of the muscle cells and dump directly into the bloodstream.
And that potassium dump is the driving force behind the drug's most severe adverse effects. We are talking about acute severe hyperkalemia.
Which is lethal.
Yes. That can rapidly lead to life-threatening arrhythmias, severe bradycardia, asystole, and just outright cardiac arrest. The drug can also cause rhabdomyolysis and increased intracranial and ocular pressure.
The FDA boxed warnings on this are massive. I mean, it's not just a monitor closely situation. There is a strict do not give list.
Absolute contraindications.
So as the clinician evaluating the chart, who absolutely cannot have this drug?
Well, the most prominent contraindication involves patients in the acute phase of major burns, multiple trauma, extensive skeletal muscle denervation, or upper motor neuron injuries.
Like a severe spinal cord injury. I need to stop you there because the timing of this is fascinating. The medical literature points out that if someone burns their hand on a stove or gets into a car crash, the risk of lethal hyperkalemia isn't necessarily immediate.
Right, it's delayed.
The risk actually peaks 7 to 10 days after the initial injury. Why is that? Like, why is a fresh trauma patient okay to get it in hour 1, but giving it to that same patient a week later in the ICU could cause their heart to stop?
It's a brilliant question, and it's all about how the body adapts to trauma. Think of a damaged muscle cell like a neighborhood that just lost its cell phone tower.
Okay.
The muscle is denervated or injured, so it panics. It builds thousands of new receptors all over its surface, frantically hoping to catch a signal. This is called receptor upregulation.
Wow. So a week after the burn, the entire surface of the muscle is just covered in these cholinergic receptors.
Exactly. Normally, receptors are just clustered at the motor end plate. But in these patients, they are everywhere.
So there are way more doors being held open.
Precisely. So when you administer succinylcholine, the drug binds to millions of newly formed extra receptors. The depolarization is exponentially larger.
And the subsequent potassium dump into the blood is massive and lethal.
You've got it. That's the exact mechanism.
Wow. Okay, that perfectly explains the why behind the contraindication. What else is on the do not give list?
Well, you also hold this drug if the patient's baseline serum potassium is already elevated, specifically greater than 5.5 milliequivalents per liter.
Right, because you're just throwing gasoline on a hyperkalemic fire at that point.
Exactly. It is also strictly contraindicated in patients with a history of or a genetic susceptibility to malignant hyperthermia.
Malignant hyperthermia, that's a terrifying hypermetabolic reaction. The literature links it to certain inherited genetic variants, right?
Yes, it's strongly genetic.
And what's crucial for the nurse anesthetist or ICU nurse to know is that using volatile inhaled anesthetics alongside succinylcholine drastically increases the risk of triggering that malignant hyperthermia cascade.
Right, it's a dangerous combination. And there's also a deeply concerning boxed warning regarding pediatric patients that every clinician must be aware of.
Right, I saw this in the sources. There are rare reports of sudden ventricular dysrhythmias and fatal cardiac arrest secondary to rhabdomyolysis and hyperkalemia in children.
Ah, yes.
And what's truly devastating is that these are often healthy-appearing kids who are later found to have had an undiagnosed skeletal muscle myopathy.
The classic example is Duchenne's muscular dystrophy, which primarily affects young males. Because their muscle cells are already structurally compromised, exposing them to this depolarizing agent causes a sudden massive leaking of potassium.
Which is exactly why the standard of care dictates that in neonates, infants, and children, you reserve succinylcholine strictly for emergency intubation, or instances where immediate securing of the airway is a life or death necessity.
You never use it for routine elective procedures in that population.
Definitely not.
We also need to touch on drug interactions. Remember how the drug relies on plasma acetylcholinesterase to wear off after 5 minutes?
Right, the backup cleanup crew.
Exactly. Any medication that antagonizes or suppresses that enzyme will prolong the patient's paralysis.
So if a patient is on, like, chronic oral contraceptives, glucocorticoids, or MAOI antidepressants, those drugs block the cleanup enzyme,
They do.
meaning a patient might take much longer than 6 minutes to start breathing again.
That's the clinical reality. You have to anticipate a prolonged block and be prepared to mechanically ventilate them much longer than you initially planned.
Okay, I have a memory hook for you to help lock in that lethal side effect we keep coming back to. When you see this drug on an exam or in the Puxis, just remember succinylcholine, SEKS, the potassium, out of the cell.
I love that. That is highly effective. It immediately links the drug name to the most dangerous pathophysiologic mechanism, which is exactly what exams like the NCLEX or ATI are going to test you on.
So knowing that this drug can cause massive potassium spikes, cardiac arrest, and malignant hyperthermia, let's step into the shoes of the bedside critical care nurse.
Let's do it.
How do we safely administer and monitor this? Let's talk priority nursing interventions.
When you are standing by that bed watching the monitor, you aren't just looking at squiggly lines. Your absolute priority is continuous monitoring of the ECG. You are actively hunting for peaked T waves.
Because a peaked, tended T wave is the very first electrocardiogram sign of severe hyperkalemia. Like, it's the warning siren before the heart stops.
Yes, and alongside the ECG, you are continuously monitoring expired carbon dioxide, the TCO2, and their body temperature.
Why the CO2?
Well, a sudden, unexplained rise in expired CO2 is often the earliest clinical sign that the patient is slipping into malignant hyperthermia.
Ah, okay. And as an elite nurse, you have to know when to confidently hold this medication and question the physician's order.
Absolutely.
Based on what we've covered, you hold it if the lab shows potassium over 5.5, is the family history of malignant hyperthermia, or if the patient is a week out from a major burn or a crush injury.
Now, let's play out the worst-case scenario. You push the drug, and suddenly the patient goes into hyperkalemic cardiac arrest. What is the antidote?
Well, for the paralysis itself, there is no traditional reversal agent.
Right.
You can't just push Narcan like you would for an opioid overdose. You literally just have to bag the patient, support their breathing, and wait for their plasma acetylcholinesterase to degrade the drug.
True. There's no reversal for the neuromuscular block. But for the cardiac arrest caused by hyperkalemia, you have to act immediately. You're going to push IV calcium, followed by intravenous bicarbonate, and then a combination of glucose and regular insulin.
Wait, hold on. Insulin? I mean, I thought insulin was just for lowering blood sugar in diabetics. How on earth does pushing insulin help a patient dying from a potassium overdose?
It's a brilliant biochemical hack, honestly. Insulin doesn't just manage glucose, it actually activates the sodium-potassium pumps on the cell membranes.
Oh, wow.
Yeah, so when you give a large dose of IV insulin, it forcefully drags potassium out of the bloodstream and shoves it back inside the cells where it belongs.
That is wild. And you give the glucose like D50 at the same time, just so the massive dose of insulin doesn't crash their blood sugar and cause a hypoglycemic seizure.
Exactly. And the IV calcium is given first, not to lower the potassium, but to stabilize the cardiac muscle membrane. It acts like a shield for the heart while you wait for the insulin to move the potassium.
And what if they trigger malignant hyperthermia instead?
Then you are immediately administering the specific antidote, which is dantrolene, and packing them in ice.
Let's shift to a major clinical point. Honestly, this is a profound issue of basic human dignity.
Right.
We know succinylcholine paralyzes every skeletal muscle in the body. It stops them from moving, it stops them from breathing. But what does it do to their brain?
Absolutely nothing. It provides zero sedation, zero amnesia, and zero pain relief. It has no effect on consciousness whatsoever.
Wait, you're telling me it paralyzes their entire body but doesn't touch their brain? Like, they can hear the alarms, they can feel the laryngoscope blade going down their throat.
Yes.
How is that even legal to administer without something else?
It is a true clinical nightmare if handled incorrectly. The clinical guidelines explicitly state that adequate amnesia, sedation, and analgesia must accompany neuromuscular blockade.
So you have to sedate them first.
To avoid unimaginable psychological trauma, yes, you must administer the paralytic after unconsciousness has been induced.
You can't educate an unconscious patient, but the critical client advocacy piece here for the nurse is serving as the final checkpoint.
Right, you are the last line of defense.
You must ensure the provider has ordered and administered the sedative, like propofol or etomidate, before you push the paralytic. Otherwise, you are trapping a fully awake, aware, terrified patient in a paralyzed body where they cannot breathe or signal for help.
Preventing that scenario is one of your most fundamental nursing responsibilities during an RSI.
Let's talk about the logistics of actually administering the medication. How is it given?
Intravenous push is the preferred route. However, if IV access is impossible, say you have a coding pediatric patient with collapsed veins and severe laryngospasm, it can be given intramuscularly.
Where do you give it IM?
If giving IM, it's recommended to inject deeply into the deltoid because the rich blood supply offers a faster onset than the quadriceps.
I also noticed a very specific chemical incompatibility in the literature. Acetylcholine is acidic, with a pH of roughly 3 to 4.5.
Yes, very important.
So you must visually inspect the IV line, and you absolutely do not mix it with alkaline solutions like barbiturates, or it will precipitate.
As for storage, it should generally be kept refrigerated. However, the multi-dose vials and prefilled syringes are remarkably stable for up to 14 days at room temperature.
Oh, that's good to know.
Interestingly, during COVID-19 drug shortages, the FDA allowed a labeled in-use time extension, allowing it to sit at room temperature for a maximum of 2 hours or 4 hours refrigerated after penetrating the vial.
And finally, how do you evaluate if the medication was effective? Obviously, you assess for adequate flaccid intubating conditions, but if you are using it as a continuous infusion in the OR, you monitor their neuromuscular function with a peripheral nerve stimulator, essentially checking their twitch response to ensure they aren't overly paralyzed.
When you connect all these pieces together, you realize the critical care nurse isn't just a TaskRabbit pushing a medication. You are managing the patient's entire physiological state.
You're anticipating problems before they start.
Exactly. You are anticipating the peaked T waves, the temperature spike, the psychological terror of being awake, and you are intercepting those risks before they ever materialize.
Okay, we've covered the cellular mechanism, the extreme dangers, the antidotes, and the advocacy. Let's say your ICU shift starts in 5 minutes. You're getting a report from the off-going nurse. Let's do our final 80-20 review of the absolute non-negotiables.
First and foremost, you need to recognize succinylcholine as your fast-acting, short-duration depolarizing blocker. You reach for it when you need emergency intubation right now.
Second, you must remember the advocacy piece. It paralyzes, but it does not sedate. You have to ensure sedation and analgesia are pushed first.
Third, your major safety radars need to be tuned to severe hyperkalemia. You are heavily scrutinizing the chart of any patient with major burns, massive trauma, or a spinal cord injury, and you are always alert for the signs of malignant hyperthermia.
And from an intervention standpoint, Your eyes are glued to the monitor. You are actively watching that ECG for peak T waves, and you are monitoring the expired CO2 for unexpected spikes.
If we distill this down to the core clinical facts, you absolutely must retain the IV onset is 30 to 60 seconds, and it wears off in 4 to 6 minutes.
Super fast.
It is strictly contraindicated if the baseline potassium is over 5.5. It causes visible muscle fasciculations before paralysis sets in. And it is a known trigger for malignant hyperthermia, so always know where your dantrolene is stocked.
And crucially, it relies on plasma acetylcholinesterase to be degraded, not the usual acetylcholinesterase.
Which actually brings up a fascinating physiological variable I want to leave you with. We know that succinylcholine's incredibly useful 4 to 6 minute duration relies entirely on that specific enzyme in the blood pseudocholinesterase to break it down.
Right. That backup system is the whole reason we use it for difficult airways.
But consider this scenario. What happens if a seemingly healthy young patient comes into the hospital for routine appendectomy, gets intubated with succinylcholine, and happens to have an undiagnosed genetic deficiency of that exact plasma enzyme?
Oh, wow. If they genetically don't produce the enzyme that breaks the drug down, the 4 to 6 minute window goes right out the window.
Exactly. This raises an intense clinical question. How long would that patient stay paralyzed? Are we talking 30 minutes, 4 hours, 8 hours?
That is terrifying.
And as the clinician at the bedside managing the ventilator, how would you recognize that this rapid-off paralytic suddenly isn't metabolizing at all, and how would you handle it?
That is a wildly intense, yet entirely possible scenario to chew on. It just goes to show that in critical care, even the most predictable, fast-acting drugs can throw you a massive, life-altering curveball if you don't fully understand the underlying biology.
Exactly right.
Thank you for joining us for this deep dive into succinylcholine. Keep questioning those mechanisms, keep fiercely advocating for your patients at the bedside, and we will catch you next time.